Peacock. I'm a professor in the Academy of Ambulatory Foot and Ankle Surgery, and this morning I want to show you a patient that we are following up who had a chronic ulceration we were able to manage with minimally invasive surgery. When we first saw him, he had a fairly significant ulceration on the plantar aspect of the foot. He ended up having to have an incision and drainage due to some severe osteomyelitis, which after the incision and drainage he was hospitalized for this, and the surgeon had to debride both soft tissue and bone. Unfortunately, after the debridement, he continued to have an ulceration here, and he developed osteomyelitis in the fourth metatarsal distally. So what we did with this, we made a percutaneous incision on the fourth metatarsal and actually elevated the fourth metatarsal. And there was a spur formation on the fifth met, which was the remaining fifth met. We removed that too. So we're able to do this in the office. He wasn't a real good candidate to put to sleep or to do hospital surgery on because of some other issues and everything. So we're able to correct this foot. Ironically, the fourth metatarsal osteomyelitis has actually improved, mainly because we're able to elevate the pressure off that. So he still technically may have some bone infection, but it's now quiet, and he's able to keep his foot. So we've been able to heal his ulceration by implementing minimally invasive surgical techniques. This is a continuation of the same video. This patient had a chronic ulceration that occurred over a year ago. He was hospitalized with an incision and drainage. The surgeon had to debride both bone tissue and soft tissue. He had remaining osteomyelitis in the fourth metatarsal head. Here's the x-ray. You can see what we were facing with. He had a bone spur residually on the fifth metatarsal, and still some osteomyelitis and bone infection in the metatarsal head and in the base of the proximal phalanx of the fourth left foot. Here's our view here underneath the C-arm. And what we're going to do here, what we had proposed to do, and this is what we're going to show you, we'll tackle this with minimally invasive surgery. So what we're going to do is make a percutaneous incision on the fourth metatarsal and perform an elevating osteotomy of the fourth met. And this will achieve a couple of things. It takes the pressure off the osteomyelitis in the fourth metatarsal phalangeal joint, and also slightly distards the infection of blood supply, so it can allow the infection to go into more of a dormant state. And in the fifth ray there, we're going to do a minimally invasive procedure and basically remove that spurring that was left from the incision and drainage that the general surgeon had to perform to basically save the guy's life. He was getting septic because of infection. We were able to do this in the office. This is his foot here, and here's a percutaneous incision over the fourth metatarsal. And this was done under the C-arm. You can see here our C-arm picture. We actually make sure under the C-arm we're in the exact location we want to be, and we're going to make our cuts in the exact location. So this is not really done blind. We're actually using the C-arm to see what we're doing here. After making an initial stab incision, I use a small elevator and a small rasp to take the periosteal layer off of the metatarsal so we don't grab any soft tissue with our Isham burr. At this point, we made our osteotomy through the metatarsal. This is done at an oblique angle, approximately 35 to 45 degrees, under the guidance of the C-arm. Once again, you can see our C-arm, making sure that we have our burr in the exact position, that we're not unduly harming soft tissue here, and that we're on the appropriate place in the metatarsal itself. After achieving the osteotomy, we also look at that under the C-arm. Basically pull back on the fourth toe to make sure we have a complete osteotomy, which we do in this case. So the next part we were going to do is actually take care of that bony spurring there, which is also attributing to the chronic ulceration. Make a stab incision there, and under the C-arm guidance, slightly denude out the bony spurring. We do this under C-arm, checking frequently to see what progress we're making. Shows our incision site here. You usually have to take a little rasp, which I did with this, to get any of the residual bony spurring out. It's getting a little better here, and then finally we left with this, and this is where we kind of stopped at. So you can see we got this spur out here with using a Isham, a short burr, and we did an osteotomy with a straight Isham. And this allowed his foot to go on the heel. Basically, here's how his foot looked. It did some amazing healing. This is his foot at approximately 2 weeks after the surgery. You can see the ulceration is already significantly better than the pre-op ulceration. Here's his foot at 4 weeks. And finally, what we have now, this is 6 months later, which is what you saw in the earlier part of the video, showing that his foot has completely healed. So he was able, this is 4 weeks here, so he was able to complete, we were able to completely resolve this ulceration with using minimally invasive surgery. It gave us the advantage of not having to cut into where we already have infected bone. And this patient also is a fairly unstable patient with his diabetes and with basically his overall health. Has a lot of health issues, so not a good candidate to put to sleep. So we're able to do this under local anesthetic. The patient does have a lot of neuropathy, so it made that a little bit easier. So we're able to attribute to his healing and get him back to normal and out of the hospital, correcting his chronic ulcerations with this. Now, it should be noted that this was a lot of different treatments as a guy before he came to us. He was on IV antibiotics. He'd also had hyperbaric oxygen therapy. So the wound was actually worse than it is when it first presented to us. And we were able to go ahead and finish it up with a little minimally invasive surgery. He's now walking and doing normal activity, even with a normal shoe on. He doesn't even wear a special shoe. So this was a great case that allowed us to correct this guy using minimally invasive techniques, and they were safe for him and office-based, and went on to a complete healing.